Welcome to This Explainer. Today, we're diving headfirst into the brand new ADA 2026 guidelines, translating them into a highly practical, evidence-based masterclass for the modern clinic. If you've been looking for a detailed, step-by-step approach to managing type 2 diabetes, from locking down that initial diagnosis to choosing the absolute best plan of management, you are exactly in the right place. Let's break down all this new science into actionable steps we can actually use.
537 million. Let that number sink in for a second. That's how many adults worldwide are currently living with diabetes right now. We're talking about roughly a 10% prevalence across the entire globe. This really highlights the massive stakes we're dealing with here. Mastering this clinical pathway, it isn't just about passing a board exam, it's absolutely critical for your everyday practice, because you are going to be seeing these patients constantly.
All right, so here's our roadmap for today. We're going to cover establishing the diagnosis, classification forensics, baseline complication screening, holistic pharmacologic management, and finally, overcoming therapeutic inertia. Let's get right into it.
Section 1. Establishing the diagnosis.
So when do we actually start screening? Well, universal screening is now officially mandated for all asymptomatic adults the moment they hit age 35. But what about the younger crowd? For those under 35, we switch to a risk-based approach. You'll want to screen them if they have a BMI of 25 or higher, or 23 if they're Asian American, plus just one additional risk factor. That could be a history of cardiovascular disease, a first-degree relative with diabetes, or coming from a high-risk ethnic group. And if that initial screening is normal, just make sure you repeat it at a minimum of 3-year intervals.
Okay, so you've run the labs. Now, these cutoff values are the non-negotiable ADA 2026 numbers you absolutely have to memorize to confirm the diagnosis. We're looking for an A1C of 6.5% or higher from an NGSP-certified lab, or a fasting plasma glucose of 126 milligrams per deciliter or higher, making sure the patient hasn't had any calories for at least 8 hours. You could also use a 2-hour oral glucose tolerance test of 200 or higher using a 75-gram glucose load. And finally, a random plasma glucose of 200 or higher, but listen, that one only counts if the patient is actually presenting with classic symptoms of hyperglycemia or crisis.
But wait, here is a massive clinical pearl. And honestly, it's where a lot of practitioners get tripped up. Unless your patient has unequivocal, obvious hyperglycemia, you literally need 2 abnormal results to confirm the diagnosis. No exceptions. That can be from 2 totally different tests run at the exact same time, or the exact same test repeated at 2 different times. Whatever you do, just don't diagnose on a single asymptomatic elevated lab value alone.
Moving right along to Section 2, Executing Classification Forensics.
Assuming every adult walking into your clinic has type 2 diabetes, that is a really dangerous game. Relying just on a gut feeling or clinical judgment leads to misclassification in up to 15% of cases. By prioritizing biological markers, we completely remove the guesswork. Step 1. Test for islet autoantibodies like GAD, IA2, or ZEN-T8. If those come back positive, you're looking at type 1 diabetes, or LADA if the patient is older. If they're negative, we move straight to Step 2. Assess C-peptide, ideally after they've had the disease for about 3 years. A level under 200 picomoles per liter strongly points to type 1, while a nice, robust level over 600 definitively points to type 2. This whole forensics approach makes absolutely sure you aren't accidentally treating a type 1 patient with type 2 oral meds.
Section 3. Mandatory baseline complication screening. The ink on the diagnoses is barely dry, but you gotta act fast. You must execute these specific screenings right at the time of diagnosis for type 2 diabetes. For nephropathy, get a spot urinary albumin to creatinine ratio and a serum creatinine to calculate eGFR. Keep in mind the stark reality here. Diabetes is literally the single leading cause of end-stage renal disease in the developed world. Do not skip this. For retinopathy, they need a comprehensive baseline eye assessment. And for neuropathy, screen for distal symmetric polyneuropathy using that simple 10-gram monofilament test, and check for cardiovascular autonomic neuropathy by asking about symptoms like orthostasis.
Which brings us to the core of our strategy, Section 4, Holistic Pharmacologic Management.
This is where things get really interesting. The 2026 guidelines push a massive paradigm shift. We're moving way beyond just lowering blood sugar. Your management plan now rests equally on 4 distinct pillars: glycemic management, blood pressure management, lipid management, and crucially, utilizing agents with cardiovascular and kidney benefit. And guess what? All 4 of those pillars absolutely must be built on the rock-solid foundation of lifestyle modification. That means serious weight management and at least 150 minutes of moderate physical activity every single week.
Now, I know the new overarching algorithm for glucose-lowering medications might look a bit like a giant puzzle at first glance, but it really just boils down to balancing 2 distinct pathways. One pathway is dedicated entirely to cardiovascular and kidney risk reduction. The decision to use these specific protective agents is made irrespective of the patient's A1C. It doesn't matter what the number is. The other pathway focuses purely on achieving and maintaining weight and glycemic goals. So you're effectively balancing end organ protection right alongside metabolic control.
Let's deconstruct this and make it super practical for the clinic. You basically just match the patient's specific comorbidities to the proven benefits of these drugs. It's that simple. If your patient has heart failure, the recommended agent is an SGLT2 inhibitor. If they have atherosclerotic cardiovascular disease, or ASCVD, you're going to reach for a GLP-1 receptor agonist, an SGLT2 inhibitor, or maybe even both. For chronic kidney disease, go with an SGLT2 inhibitor or a GLP-1 if the SGLT2 just isn't tolerated. And for metabolic liver diseases like MSLD or MASH, the guidelines firmly point to a GLP-1 or a dual GIP/GLP-1. Remember, these are deployed for sheer organ protection, completely regardless of where their blood sugar currently sits.
And finally, Section 5, Overcoming Therapeutic Inertia. Okay, so we've got the diagnosis, the forensics, the screening, the meds, the whole shebang. But look, even the absolute best clinical plan is going to fail if it just sits there gathering dust. It boils down to these 3 non-negotiable checkpoints. Checkpoint 1, treat the patient, not the number. You've got to individualize your A1C and blood pressure targets through shared decision-making, keeping in mind life expectancy and other comorbidities. Checkpoint 2, end organ protection is paramount. Glycemic control is no longer the sole metric of success. Getting those cardiorenal risk reduction agents on board is mandatory. And checkpoint 3, overcome therapeutic inertia. You have to reevaluate the treatment plan every 3 to 6 months. Delayed intensification practically guarantees irreversible beta cell failure. You simply cannot afford to wait. So as you step back into the clinic to put this evidence-based pathway into practice, I want to leave you with one final provocative thought based on these 2026 standards. When you look at that patient sitting across from you in the exam room, are you just treating the lab number, or are you truly protecting the patient? Keep that question front and center in your mind. Thanks for joining me for this explainer, and I will see you next time.